2 lives, 1 decision, and only minutes to prepare.
A dynamic clinical model of obstetric anesthesia integrates shifting anatomy and complex pharmacology into a single, comprehensive first principles framework. The laboring parturient presents a unique challenge because she represents a dynamically shifting physiological environment. As labor advances, the underlying neuroanatomy changes, requiring anesthetic interventions to adapt to that progression. The clinician must balance this moving anatomical target while mitigating distinct risk profiles for both the mother and the fetus. To build this model, we map the baseline procedural setup, track the exact dermatomal progression of labor pain, and define the parameters of operative intervention. A static approach to the obstetric block overlooks the dynamic nature of labor, increasing the risk of failed anesthesia. We will map these procedural requirements against the anatomical progression of the parturient. Before initiating any neuraxial block, the procedural baseline must be established. You need immediate access to oxygen, access to resuscitation supplies, reliable wall-mounted section, and a secure intravenous line. During placement, positioning the patient laterally rather than sitting limits the movement of the lumbar spine while they endure active contractions. This illustrates the breakdown of a standard epidural test dose: 45 milligrams of lidocaine combined with 15 micrograms of epinephrine. Epinephrine is highly unreliable as a test marker here. Labor induces extreme heart rate variability, rendering the data erratic. Direct aspiration of the catheter prior to injection to observe for blood or cerebrospinal fluid provides a mechanical alternative to this noisy pharmacological marker. This method provides high certainty, carrying a 0% false positive rate and a 0.2% false negative rate. When operating in a highly volatile physiological state, direct mechanical verification consistently outperforms indirect pharmacological markers. Timing the intervention requires adhering to strict thresholds. Epidural placement should be avoided during the latent stage of labor, specifically when cervical dilation is less than 4 centimeters. Placing the epidural too early increases the clinical risk of dystocia. As seen on this spinal map, the primary pain pathways during the first stage of labor are localized within the T10 through L1 dermatomes. Covering these specific dermatomes requires choosing between 2 primary local anesthetics, ropivacaine or bupivacaine. This chart compares their pharmacological profiles, showing ropivacaine produces significantly less motor block. It also provides a superior safety margin, with a fatal dose threshold twice that of bupivacaine. Overall, it's 25% less toxic, producing fewer central nervous system symptoms. Clinicians select ropivacaine in early labor to maximize sensory block and preserve motor function while expanding the safety margin against systemic toxicity. As the patient enters the second stage of labor, a distinct neuroanatomical shift occurs. The transmission of pain becomes primarily perineal. Returning to our spinal map, this expanded pain profile necessitates a broader blockade, requiring coverage from T10 all the way through the S4 segments. In scenarios such as a forceps delivery or an episiotomy, targeted perineal relief is required if systemic epidural coverage is insufficient. The pudendal nerve block provides this specific localized intervention. This is executed via a transvaginal injection, utilizing 10 milliliters of dilute local anesthetic. This directly anesthetizes the S2, S3, and S4 nerve roots. Isolating these exact roots grants profound operative relief for delivery mechanics without exposing the patient to the risks of massive systemic dosing. Routine labor can rapidly escalate into a high-stakes operative delivery, requiring an immediate transition to cesarean section protocols. Abruptio placentae is the primary absolute contraindication to regional anesthesia in this setting. The sympathectomy and resulting hypotension produced by neuraxial anesthesia in this state would jeopardize uterine blood flow and fetal oxygenation. This digital medical chart shows the other strict threshold. A maternal platelet count of less than 100,000 prohibits the use of neuraxial techniques. If no contraindications are present and an epidural is already in place, it can be dosed up to meet standard cesarean section requirements. On our spinal map, this requires the target sensory blockade to extend to the T4 dermatome. Spinal anesthesia is the most commonly utilized technique for a C-section due to its rapid onset, reliability, and procedural simplicity. The precise pharmacological formula for this spinal block is 1.6 to 1.8 milliliters of 0.75. The paralytic is paired with an induction agent, propofol at 2 milligrams per kilogram, ketamine at 1 milligram per kilogram, or etomidate at 0.2 to 0.3 milligrams per kilogram. Ultimately, safe obstetric anesthesia matches the pharmacological agent to the correct dermatome at the exact phase of labor. Safe navigation of the parturient's physiological landscape requires matching each intervention to these specific anatomical boundaries.